I'd like to thank all of you for joining us today. This is actually session 2 of our Family Leadership Institute, and today we're going to be discussing the understanding and how we are working with state agencies. And we have Sarah Dunn from the Minnesota Department of Health with us to impart very valuable knowledge. If you could, please mute yourselves for the majority of the presentation, but know that you can always raise your hand or chat in the chat box, or if you have some questions. We really want this to be interactive if you do have questions. And Sarah, that was okay with you, right? If we need some clarification?
Totally.
Thank you so much. Today's objectives are getting to know each other a little bit. We're going to kind of develop just a little bit of a connection here so that we can have our increased and enhanced connections and network building here. Getting to know the roles of different state agencies in Minnesota. We're going to dig deeper into the role and responsibilities of the Minnesota Department of Health. And Sarah's going to tell us a little bit about Title V and the Maternal Child Health Block Grant. So let's see, if we would like to start with some introductions, I think it would be very, very nice. Let's see, I think something that could be really helpful would be to state your name, whether or not you are in cohort 1, which is typically, I think, everybody who's on staff, and cohort 2, that's all of you that are joining us this year. You could tell us maybe your city or your county, and then if you could name your top 3 themes or strengths, that would be awesome. So what we'll do is we'll start with the first volunteer, and I'll grab my master sheet so that if you don't have your top 3 themes with you, I can read them off for you. But anybody who wants to volunteer who has their top 3 themes memorized would like to tell us their name, city, county, and the top 3, that'd be great. Don Bly, I see as usual you are on the ball.
I don't know if on the ball or just eager.
Both are great.
I'm Don Bly. I am from Fosston, Minnesota, which is up in Polk County in the northwest part of the state. My top 3 are learner, connected, and responsibility. And they really are who I am.
This is Jamie. I can go next. That's all right.
Yes, go ahead,
you want me to
please.
Go? Okay. Jamie O'Connor, Richfield, Minnesota, cohort 1. And my top 3 are connectedness, input, and developer.
Thank you, Jamie. Any volunteers to go next?
I'll jump in. I'm Brenda Hudson from St. Paul, cohort 2, and I think my top 3 are empathetic, developer, and connectedness, I think.
Ding, 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 you are correct.
Good. Nice to
Thank you, Brenda.
I can go next. This is Megan Banks up in Sartell, so right up by St. Cloud, Minnesota, in cohort 2, and my top 3 are learner, arranger, and developer.
Megan, where did you say you were from?
I live up in Sartell, so it's like a suburb of St. Cloud.
Yep, I have driven through.
Mm-hmm.
Thank you.
This is Lori Kovish. I live in Dakota County, South St. Paul. I'm looking for my list, so I must not be like the organized one, but if you could tell me my top 3, I would love it.
Lori, your number 1 is woo, your number 2 is empathy, and number 3 is belief.
Yes, not organized 100%, but thank you.
You're welcome. Thanks, Lori.
This is Mia.
Hi, Mia. Go ahead.
Hi. Okay. I didn't see anything. I'm in Mendota Heights, which is Dakota County. I'm cohort 2, and my strengths are strategic, intellection, and individualization.
Thank you, Mia.
This is Carrie. I'm in cohort 1. I'm in North Mankato, which is Nicollet County, and I am empathy, strategic, and developer.
Thank you, Terry.
I'll follow Terry.
Hi, Mary.
Hi, I'm Mary, and I'm also in North Mankato and Nicollet County, just like Terry. My 3 are empathy, belief, and connectedness.
Wonderful. Thank you so much. Terry or Tony, are you speaking and still on mute?
I'm so sorry. You're right. Alrighty, now this is Tony, and I am in Ramsey County, Maplewood, and I also am in cohort 2, and Tricia, you're going to need to help me. I'm not organized. I don't have the top 3 with me.
Tony, you are harmony, consistency, and belief.
Thank you.
Let's see. We have left Sarah St. Louis, Sarah Reiners. If you can join us.
I can
Jessica.
quickly. Sarah. I am. Can you hear me?
Yep.
Okay. I'm cohort 2 in Hennepin County, and I believe mine were communication, learner, and connectedness.
That is correct.
Ah, awesome.
Thank you.
Sarah Reiners. I'm in Bemidji. I'm sorry, I had an appointment that went late, so I'm just driving my son home right now.
That's okay. I can read off your 3.
Do you have
I have you as responsibility, woo, and futuristic.
Yeah, I knew woo and responsibility, but yeah. Okay, thank you.
You bet.
Hi, this is
Jessica
McCain. I'm in Otter Tail County, Hewitt, Minnesota, cohort 2, and my top 3 were responsibility, harmony, and deliberative.
Thanks, Jess.
This is Kelly Corpola. I'm in Stearns County. I live between Annandale and Clearwater, cohort 1. My top 3 are belief, responsibility, and harmony.
Great, thank you. Anyone we have not heard from? Carolyn, did we hear from you?
No, this is Carolyn Allshouse. I was part of cohort 1, and I live in Hugo, Minnesota, which is in Washington County. And my top 3 were ideation, intellection, and connectedness.
Anybody we've missed? Well, just as a reminder, we're going to ask Sarah to share hers too, because Sarah Dunn has done this, much like we have. But I just wanted to remind everyone, we encourage you to, I don't care if it's on a piece of paper and you have your children get creative with the crayons, but put your top 3 or your top 5 somewhere where you can remember these and remind yourself that this is what you lead with every day. And this is what I did. I did a little coffee mug, and I've got my top 5 written on here, and you probably can't read them, but I can. So that's all that matters. But put them somewhere where you can really just even subconsciously look at those and have those around you, surrounding you, so that this is how you lead, and a good reminder of your family leadership experience as well. So unless there's anything else that I have missed for today, to start off, I would like Sarah Dunn to please introduce yourself, give us your top 3, and I also want to say thank you so much for joining us today. We really appreciate your time and the energy and the presence you bring to this Family Leadership Institute.
Yeah, no problem. I'm really excited and honored and all of those words to be here with you guys today. And so I will, start off, like I said, first things first, let's get to know one another. And so a little bit about me. I, as you could tell by the name change, recently was married back in May, and so that is a picture of us from our wedding day, all happy and all I don't know, whatever those things that you are on your wedding day. And so a little bit about me. I am from Iowa originally, and I come from kind of a medium-sized family. There are 4 kids, and I'm the oldest, and we've got sort of 2 family life cycles going on, because the youngest of us is just now in college, and so, and I'm not going to say how old I am, but anyway, I moved to Minnesota about 6 years or so ago. Before that, my training, my educational background is in social work, and I worked for the state of Nebraska in their Division of Behavioral Health for about 5 years as a master social worker, and then I moved to Minnesota, and I now work at the Department of Health. I've also gone back to school since I've moved here and have a public health degree as well. And now I've been with the Children and Youth with Special Health Needs program for about 5-6 years. Not quite the whole time I've been in Minnesota, but nearly that. I've been a supervisor for the last 2 years in the program, kind of have moved up a little bit. And otherwise, those are our 2 kitties. We're a blended family, so the one that does not have a hat on because she bit me as I was trying to put it on is Callie. She's my cat, and then that's the other cat in the picture is Charlie, and he's Matt's cat for sure. And so that was from our Christmas card last year. But that, probably I would say the thing about us, that we kind of like the most is traveling, and we've done a whole lot of that as a couple and have lots more plans to do that as well in the future. So my top 5 strengths. I'm glad I am saying my top 5 because I always get a little bit my top 3 are thinking ones, but I do actually have some I do actually get things done as well. And so my top 5 are intellection, input, learner, futuristic, and significant. And so I would love to hear just a little bit more about you guys. To have a little bit of conversation. Our topic of our presentation today is understanding and working with state governments, and as a state government employee, I love having conversations with folks about this, and so I thought maybe I've already heard your names and where you're from, but maybe we could do a little bit of a question. And if you don't have any ideas, that is perfectly fine. But I thought maybe an icebreaker before we dig into like who does what in state government could be, what is one like crazy big idea that you have that could improve a process or a policy or a program in government in Minnesota? So I wrote down folks' names as you went, and so I might just, rather than having like you chime in as we, like you kind of individually, I might just call on names. And if you don't have any ideas or don't want to say anything, you can totally pass. It's just kind of a question. And I would say my crazy idea, and it doesn't sound that crazy, but a little bit it feels like it is a crazy idea, is we at the Department of Health, we don't have a really great connection with our Department of Human Services, and I would love to have one person at DHS who I could call and talk to if I need something. And so that is my crazy big idea. Just the more interagency work and having one contact. So, Dawn, I think that you were the first person who spoke earlier.
I do have a crazy idea. I don't think it's that crazy, but it appears to be a very crazy idea. As an educator, my crazy idea is that we get rid of special education. How about just educating all kids as they are, where they need and what they need to know? I think that because education or special education was put into education years ago, it just has started the path of exclusion versus inclusion. So that's my crazy idea.
I love it. Jamie.
So my number 4 is intellection, which means I usually like to chew on a question for a while.
That's fine. I can totally.
No. I will reply, and but my crazy idea would be that anyone who is working in a state agency or working with individuals with disabilities would undergo a behavioral therapy so they could understand how their perceptions impact their work.
Mm-hmm. Brenda.
Had I known this, I would not have volunteered early in the process. No, I'm kidding. I don't know. I don't have anything specific. This is super generalized, but anything that can make communication with people we need to be in touch with more humanized. Like sometimes it feels like whenever I'm dealing with any kind of agency, it's just, I don't even know who's out there. Like, how do you make a connection? I guess connectedness is one of my strengths. And I just feel like so many times you just reach out and you have no idea, at what level you have to kind of explain yourself or who you're going to get on the other line. So on the other end of it. So I don't know what that translates to, but that's my offering anyway.
Yeah. Yeah, I agree. We have the same thing when I try to communicate with someone just in another agency. Like it's the same thing. Yeah. Megan?
Yeah, I guess I don't have a lot of experience working with state government. Most of the things for my son, we do not qualify for government help. So we do mostly our private insurance. But I guess one thing when I'm dealing with people who are working with my son, I do wish that there was more for that intermediate age. There's a lot of early intervention programs, but my son is in middle school and it's a really, really hard transition, and there just are not a lot of resources for him.
Mm-hmm.
It's all geared towards little kids or adults.
Yeah. That's very true. Mm-hmm. Lori?
Yes, I'm here.
Do you have a crazy big idea? If not, that's totally fine.
Well, I am Lori and I'm from South St. Paul, and one big thing that's impacted me that I didn't know was such a big deal was the whole grief thing. When you're going through the whole process of your child being disabled, they really never talk about death. And so like more awareness around that arena would be like, you know, even kind of a plan along the way, even if you have a young child or person, like something to be more implemented into the whole healthcare process.
Mm-hmm. Mm-hmm. Mm-hmm.
So that's a big idea for a, you know, kind of a more of a rare thing, but it does happen, and you don't really plan for it.
Mm-hmm.
And then what happens after that, and how to deal with it along the way, because you're actually in grief process the whole time. Your child is that way too, and nobody really talks about that or helps you.
Mm-hmm.
Thank you.
Yeah, thank you. Mia?
I would want more transparency from agencies and less red tape, so that it's easier to actually know what you're signing up for or what you aren't signing up for, instead of having to know the right words and feel like people are talking in code around you.
Yeah. Mm-hmm. Terry?
Can you hear me?
Yes.
So my big idea is that no matter what county you're in or what social worker you talk to, they all give you the same answer. So that especially those that are trying to support other people, you know, we can kind of know what to expect and kind of help them through the process.
Yeah. Yeah. Mary?
Mary, you're on mute.
Thank you.
I agree with Terry 100%, and I'm going to add to that a little bit because I'm in North Mankato, I'm in Nicollet County. We kind of have the mini twin cities down here, with Mankato being right across the river in a different county, Blue Earth. However, we're all the same school district. And so my child, and we have different social workers, obviously. So my child isn't getting things that children with similar diagnoses get from the other county across the river. It's a huge struggle, and with my son's diagnoses, early intervention is the key term, and to try and get things that he needs, it's not early. It's not early enough. 6 months isn't early enough waiting for things that he needs. Or 9 months. And so it's financially, it's a huge strain.
Definitely. Tony?
Yes, thank you. I'm right there with Terry and Mary about the state and county and how they work together. I'm envisioning, I know this idea has probably been brought up many, many times, but I just envision having, I know we have case managers, but having one person, like a care coordinator for the healthcare industry, does to be able to take everything you need and just kind of funnel it through. So you make one phone call and that person can help you with whatever it is that you need. Now, it's just, it's amazing how when you call one or the other, no one seems to know what the other one is doing. So somehow, if we can streamline that, that would be terrific.
Definitely. Sarah, St. Louis.
Okay. You hear me?
Yes.
Okay. I think, kind of what they're saying, it's that you get such a runaround with trying to get a hold of the county or whatever. And, I think that a lot of us are fairly educated on like the system at some level. But I just imagine, people, and we have such difficulties. So, those that have no idea what to even do, it's, I can see how they can just give up very easily and just, well, it's not available or the person won't call me back. And, I've had some good luck with Headway. They've been helping with my older son with his depression stuff. And they have been, the person we have, she will even, check on waiver, where grant money is for us or help sign up for stuff. So I found her to be very helpful, but I know that Headway really only deals with like a very small segment of the thing. But it's so difficult to, like we didn't even bother with Hennepin County. We tried to get with Hennepin County and our caseworker, she came out and then she completely dropped the ball. And then because I wanted to get him into the system before he turned 18. And she totally dropped the ball and then waited till after he was 18 and then said, oh, well, maybe you should just go to Social Security, SSI or something. And I'm like, well, that's not what I wanted. What I wanted were those things. And then you could never get a hold of her. And the lady from Headway couldn't even get a hold of her. So they just dropped off the face of the earth. So, having a much more streamlined system where you can make the one call and then everything's taken care of would make our lives so much easier.
Yeah, I agree. Sarah, the other Sarah, Sarah R. I don't remember your last name.
Can you hear me?
Yes.
Okay. Yeah, I totally agree with everything everyone else is saying as well. I have 2 kids with a lot going on, so it's constantly, I feel like the paperwork, the release of information, I just had to do paperwork for one kid and then I get bombarded with 12 pages for the next. I just wish that they had some sort of care coordination, some sort of consistency between the programs, that when we do use the programs that more than likely we're going to need for these kids, that there's some way that we can at least coordinate things. I know that the IRS lets us like pull stuff, like income stuff off of their website and give it for a little bit easier, but I just wish there was just like a universal release of information so we didn't have to sign those 24/7 and all these paperworks that we have to fill out. It's just so overwhelming when it's one kid, but when you add in another kid, I mean, I feel like it's a full-time job and I just want to hire somebody to do my paperwork.
Yeah. Definitely. Yeah. Jessica?
Well, I feel like everything that has been said before me is also a great idea, but I was thinking about just the timelines of from when there is a need identified that you need assistance to actually getting it implemented, which is a lot of red tape and jumping through hoops. But I just think it's really disheartening that your child may qualify for a service, but it won't be started for 6 months, which is just really, it's the child and the family that suffers. So I would like to see more streamlined processes.
Yeah. Kelly?
I agree with everything that's been said. One thing that would help, I guess, right now, because I have a kiddo that's graduating this year, is having the school districts all have the same sorts of help for our kiddos, so families don't have to feel like they have to move. Right now, I have a kiddo that would benefit from a transition program, but we don't have a transition program for a child of his ability. We have below level, but we don't have above level. And there's a ton of kids like my older son that would benefit from having a program, just having the ability for all the districts to meet our kids' needs, I guess, and not have to move to another county or open enroll, finding a way to get the districts the support they need to help each kid.
Yeah, yeah. Tricia?
I see your hesitancy in calling on me. No, I think that one thing I've learned in my family leadership development is there's a core component that if you put that into place, it could address, I think, almost every single thing that everyone has said so far. And that is one of the core philosophies of patient and family-centered care, that is having families at the table as a partner in every step, including the design, the implementation, and the evaluation of every process, policy, or program that these entities try to put forth. Don't ask me later on how did that work for you, but bring us to the table as equal partners in the design, implementation, and evaluation of all of these things, and we'll see efficiency go through the roof.
Yeah.
Efficiency and effectiveness.
I agree. I see chat. Carolyn.
Well, Tricia probably put it much more articulately than what I had in mind, which was I just think parents ought to be running the whole thing. We ought to be in charge of all the programs and designing them and implementing them, and the systems would be much better.
Yeah, yeah. You know what? I agree with you. I'm not a parent yet, but I fully agree with you. Yeah. So I am gonna move on a little bit and kind of get to like the probably rather boring part of the presentation. And so a little did you know, and I actually just learned this myself like a little like fairly recently, but Minnesota has over 160 state agencies, boards, and commissions. And so that ranges from like the Board on Accountancy to like the State Zoological Garden. And so when you talk about red tape, like just the fact that we have 160 different like agencies, boards, commissions, that kind of thing, like speaks to that problem. We today are going to focus on three main state agencies whose work impacts children and youth with special health needs. And so it's the Department of Human Services, Department of Education, and then the Department of Health, which is where I am again. And just as a reminder, I'm employed by the Department of Health, and so I can't necessarily speak too much to specifics on the other or problems of the other two state agencies. But so I'm going to provide pretty high-level information that you may already know, but I think it's always good just to kind of get a reminder of that, and just to help us all understand, you know, each of our roles in our system. And so I will say probably the state agency that the Department of Health gets confused with the most is the Department of Human Services. And so the Department of Human Services in our state is the largest agency. They receive about 1/3 of the state's entire budget. And so their real main purpose is to help provide essential services to Minnesota's most vulnerable residents. A thing to know about DHS is that they aren't actually providing those services themselves for the most part. They are more the party that is responsible for setting the policies and directing the payments for the services that are delivered. They have providers and community partners who they work with to actually provide services. And, you know, a lot of you guys, you talked about, you know, working with your counties. And so a lot of the Department of Human Services, a lot of the work they do is administered via the tribal and the county community, or human services offices. And so just some of the responsibilities of the Department of Human Services, there's a lot more responsibilities that they have, but I tried to kind of think of the most applicable for working with like children and families. And so that is administering Minnesota healthcare programs, which includes like our Medicaid medical assistance program, TEFRA and waivers. They offer economic assistance for qualifying families. And so that economic assistance includes like the Minnesota Child Care Assistance Program, the Supplemental Nutrition Assistance Program, housing and income assistance as well. They oversee the child protection and child welfare services within the state. Kind of along with Minnesota healthcare programs, is that they administer the Early Intensive Developmental Behavioral Intervention, the EIDBI benefit, which is our autism benefit in the state. And then they also manage a lot of the publicly funded programs that support persons with disabilities. And so Minnesota's healthcare programs include the state's Medicaid program, which is called Medical Assistance in Minnesota. And then they also administer the TEFRA option, which you guys probably are all very aware of. And it helps allow for eligibility for Medicaid for children who have disability whose parents have an income that's too high to qualify for MA or other Minnesota healthcare programs. Or who would qualify, but the cost is too high for those other programs. Minnesota Care is another healthcare program, the Family Planning Program, and then home and community-based waiver programs, which includes like the brain injury waiver, community alternative care waiver, the CADDY, the Community Access for Disability, the inclusion waiver, consumer-directed community supports, and then the developmental disabilities waiver as well. So, in my experience in working with families, there isn't as much confusion over the role of the Department of Education, so I really didn't include much on the Department of Education other than I did find this quote to explain what they do to be fairly interesting, because to me, when I read like this, is that they see themselves responsible for a whole lot more than just school. And so, which is, I'm not going to go off on an editorial kind of way with that, but just it's something important to think about. And so that was like a super quick overview of education and human services. And now I'm going to just dig a little bit deeper into who we are at MDH and what it is that we do to help out with that. And so our mission at the Department of Health is to protect, maintain, and improve the health of all Minnesotans. And our vision is for health equity in Minnesota, where all communities are thriving and all people have what they need to be healthy. So this slide is super busy, and I don't expect you to be able to read it all, but this just provides like some examples of different things that we do at the Department of Health. And so we house the vital records program like in our state. And so that includes like issuing birth and death certificates. We do bud assuring for infectious disease. We do monitoring and like assurance for water and food in the state. We respond to disease outbreaks and public health emergencies, such as like a few years ago, there was a measles outbreak that we really took the lead in working with Hennepin County to try and respond to that. Investigations into novel illnesses, something I think about that you've probably heard about in the state is some of the vaping related illnesses that we've been seeing in some of our young adults and adult populations. And so the Department of Health has been central in investigating that and really trying to figure out what is contributing to the illnesses and the people who are doing the vaping. We work a lot with hospitals and healthcare systems, and so some of our work around there is helping them, if we have like an emergency where a large number of people are injured or become ill, helping them to be prepared to respond to that. We do immunizations. There's so much. We, a big part of public health is epidemiology, which is like the study of trends in health. And so we have a lot of data, we study economic trends, public health concerns, different conditions that we're seeing rise, that sort of thing. We do a lot of work to help improve the care provided in our healthcare system. And so that's a lot of what we do in our Children and Youth with Special Health Needs program that I'll explain a little bit. We house some food programs for women, infants, and children. We do a lot of health education work around health behaviors and chronic disease. And just, we have an environmental health and a public health lab that looks at like pollution and risks to health associated with that. So MDH does a whole lot of stuff. This slide shows our organizational chart. Our commissioner is sort of like the head of our department, and our commissioner is appointed by the governor. Our commissioner is Jen Malcolm, and she has been in this position for a few years. She actually was appointed under Governor Dayton and then was reappointed under Governor Walz. And so if I actually did like a correct organizational chart, at the top would be like the governor, and then it would be the commissioner. There are 4 bureaus in the Department of Health, and so the Children and Youth with Special Health Needs program that I work for is in the Health Improvement Bureau, and we are in the Child and Family Health Division. I don't expect you guys like this. It's probably like it's just help. It may be helpful for you if you're one of those like structural people that you care about that kind of stuff, but it's not necessarily like needed information that you need to know. So again, I'm with the Children and Youth with Special Health Needs program, and our mission statement is to protect, promote, and improve the health of children and youth with special health needs and their families. And so in our program, in our section, we have 3 units. I am the supervisor of our capacity building unit, and then we've got a unit that responds to and does long-term follow-up for newborn screening conditions, and so that's our newborn child follow-up. And then we have another unit whose work is around doing monitoring and some follow-up for children who were born with a identified birth defect. We receive a lot of our funding from the federal government, and so a lot of that comes from our Title V Maternal and Child Health Block Grant. We also are funded by a whole bunch of other grants that we get from the federal government, from like the Health Resources and Services Administration or the Centers for Disease Control. And then we also get quite a large portion of our funding from state funds. And so Some of the state funds are legislatively allocated to us through like the budget, and then some of them are through like the fees that are like newborn screening fees. So our this is a like probably almost too simplified version of some things that we do as a program, but I would say that, and so we've divided it into 4 kind of categories. And so we do surveillance, we do prevention and upstream approaches, we do a lot of work around supporting families and communities, and then we do a lot of work around promoting comprehensive coordinated systems. And so inherent in all of that work, we really aim to partner with families in everything that it is that we do. We aim to use evaluation to really evaluate everything we're doing to make sure that it's effective. And then we also aim to try and have a policy impact with everything that we do. And so I'm not going to go too much into each of the like nitty gritty of it, but just sort of a little bit. I'm just going to kind of cover a few things here and there. So for our, yes.
If you wouldn't mind going back a slide, if you cover this later, I apologize. But, we did a survey prior to getting all of this put together, just to kind of see where everybody was at with their understanding of state agencies. And we don't know who said what on the survey. We didn't track that. There was one person who said, MDH, the Minnesota Department of Health, that doesn't really apply to my family. And that is exactly what I said before I fully understood what the Minnesota Department of Health did. So when I look at this slide, I think about how, okay, that's what you do. But I now can say, yes, MDH intersected with my family newborn screening, and some of those things. Would you mind just kind of listing off a few specifics that are the intersection between our families and these 4 points?
Newborn screening is probably a really good example of that. And so, I can't remember, but I think about almost like 99% of births in our state. We do have universal newborn screening in our state, or nearly universal. It's about 99% of births or something like that. It's really, really high number that most states don't have as high as we do. And so, nearly every child or every infant when they're born, within like 24 to 48 hours receives a hearing screen, a blood spot screen, which is when they like prick the heel of their foot, and then they test them for many like metabolic and heritable conditions, and then they also receive like a pulse oximetry screen, which kind of is intended to screen for some like critical congenital heart conditions. And so, like I said, almost every single person is impacted or receives newborn screening. 96% of births are birth defect surveillance program touches, and so we have an active surveillance system, which means that we go in and look at the birth records from hospital data, and really to help see if there are any particular conditions that maybe there are trends in our states, or if there are any sometimes we're called there, if there is like a concern, like there's maybe an environmental pollutant in a certain area, we can pull the births from that area and see if there's an increased number of children who are born with a certain condition that we know maybe that pollutant is contributing to. We do a lot of work with primary care and even venturing into specialty care providers around care coordination in medical home. And while I know things aren't perfect by any means when it comes to those kind of areas. We have done a whole lot of work to reach out to care coordinators and to primary care providers, specialty care providers, to really help them improve care that's provided. You know, there are some even kind of cool things that we're working on that you wouldn't necessarily think, oh, that really impacts me, but they're kind of like upstreamy kind of approaches. Like we have been doing some work to look at who it is in Minnesota that are being born with neural tube defects, and so that can include conditions like spina bifida, that kind of thing. And we found that there are certain populations who have higher prevalence of those, and so we've been kind of doing some digging into why that's occurring. And for instance, we've seen that there has been kind of an increase in those conditions in our more Latino, Hispanic population in the state, and that they are, you know, a lot of neural tube defect conditions. They talk about the importance of having folic acid, you know, in your prenatal vitamins, or that kind of thing, or just, you know, mothers, women of reproductive health age, you know, the importance of getting folic acid or folate into their diet. And so one thing we have found is that there, you know, from a public health standpoint, there has been a lot of fortification done into wheat products like cereal and breads and that kind of thing. However, there hasn't necessarily been as much fortification into corn products. And that population are you know, they're higher consumers of corn masa flour, you know, tortillas and that kind of thing. And so we've done some looking into how we can work with producers of masa flour to fortify their flour. And so while that may not be something you would think, oh, what the work of public health is doing is impacting me, like it completely does, you know, if we're changing like our food sources. Those are just some examples I can think of off the top of my head.
Excuse me, one of the other things I wanted to say is that, you know, I think the Department of Health, especially the Children and Youth of Special Healthcare Needs section, I've seen some really intentional, active steps toward partnering with families in those areas of design, implementation, and evaluation. And you might talk about that more when you talk about Title V and stuff, Sarah, but that to me is what has lasting and sustainable effects and impacts for families. So I think that's really great.
Mm-hmm. The one thing I don't have on here, but is included with that, like partnerships with families, is that we, the group right now is kind of on a hiatus, and we're figuring out the best way to work and really engage with family members, like on an equal colleague, you know, kind of basis. But we have had a parent work group in place for, like, since I started with this section probably 5 years ago. And that group has really been instrumental in when we're thinking about applying for grants or starting new programs or anything like that. We go to them and we want, like, even before we think about like starting a new program, we go to the parent work group to hear what the needs are so that we know even how we should, you know, approach funding or that kind of thing. So I'm going to skip through some stuff because I talked a little bit about the birth effects, and I'm kind of planning on integrating like how we partner with families into each of these. Another thing that we do in our section is really promoting developmental and social emotional screening. And so that's another kind of program that might touch a lot of families. And so we know that early screening leads to early diagnosis, And then if you get that, then, which, and then when you pair that with early intervention, you have better lifelong outcomes. And so we know that a lot of different people, a lot of different players in the system are doing developmental screening. We know it's happening in primary care. We know that it's happening in the school districts. But we also know that there are some kids who are still falling through the gaps and aren't getting screened. And so we have a follow-along program that works with local public health to make sure that some of those kids who typically fall through the cracks are receiving appropriate screening. And then I talked a little bit about like the prevention work around like our corn moth flower work. Supporting families and communities. We provide grants, one to the Family Voices of Minnesota and one to Minnesota Hands and Voices to provide direct parent-to-parent support. Sorry, I'm going to take a drink. And those grants are really some examples of how we've worked with families to help provide input and guidance to us on how we should structure those programs. And really it was the fact that we were hearing from families that, you know what, like kind of one of the best ways that you can support me is to link me with another family member. It was through hearing that from families that we decided to focus some of our block grant funding around providing or around building capacity in our state to provide more parent-to-parent support. And then the parent support that is provided by Minnesota Hands and Voices is really focused on families who have children who, through newborn screening, were identified with hearing loss. And then other ways that we work to support families and communities are working with local public health and doing long-term follow-up for children who were born with an identified condition, birth defect condition, hearing loss, and then some selected newborn screening conditions. And then another area that we really are starting to kind of branch into that we're really seeing opportunities to engage with families are writing more white papers and issue briefs around topics that can be used as a tool for families to advocate to our legislature or to others to really get the supports and help that they need. And so, for instance, we recently, we haven't formally released it yet, but we have a white paper that we've been developing around transition to adult health care. And there was much engagement with families to develop that paper and to help us figure out what our recommendations are, that sort of thing. We also have a staff member on our staff who her main role is around family professional partnerships and to really make sure that we are engaging with families and really including them as partners in all the work we do. And so Sarah is the staff member. There's a lot of Sarahs on our staff. The staff member who does that, her name is also Sarah, and she's wonderful, and she has lots of connections with Carolyn and Tricia.
Could I add something here? Yeah. Or something that I didn't know early on. I was like, what's a white paper? Sounds important. What's a white paper? And the best way I can put it is it is something written based on the issuing body's philosophy, data they have, that is used to really kind of outline a really complex issue and be given to those who have decision-making power to help inform their decisions. How'd they do? Was that?
Yeah, that's exactly the purpose of it. Yeah.
So they can pass this along to Governor Walz and the feds and all sorts of people to say, here's what we need, or here's how you can look at this problem and really see where the dollars will impact something, or you put your attention here, we will get a positive impact from it.
And the thing about like using them as a tool for advocacy is that, you know, we can write reports and release them every day, and they're never going to get any traction. But when we work with family members to write those issue briefs and reports, and then when we work with family members to pair bringing that report with their own personal story, that's when you really get the change to happen. And so
that's where family leaders come into play, because all of you have the skills, tools, and the experience to share a family story and a family situation in order to really demonstrate a need or the importance of a certain program or policy.
Definitely. Then kind of the final area I had was around promoting comprehensive coordinated systems. And that's before when I was talking about a lot of the work that we do with providers and care coordinators and that sort of thing to help them improve the actual care that we're providing. And so I would say, you know, actually, the Children and Youth with Special Health Needs Director from Florida did a really good job kind of explaining how it is that like we as a children and youth, like a Title V Children and Youth with Special Health Needs program really does this work. And so what he said was that, you know, we all agree that, you know, children and families need to receive like the best care. And we know that the best care is provided in a system that provides like team-based care. And our role as a Children and Youth with Special Health Needs program in that system is to equip those team members. And so it's our role as a Department of Health to equip, you know, our physicians, our local public health, our care coordinators, all those people who are providing care to our families and to the children, to equip them to do as good of a job as they can do. And so that is really our goal behind this area. And so what, you know, we do a lot to provide technical assistance, providing webinars, conferences, one-on-one technical assistance. And then we have a lot of, we distribute quality improvement grants to clinics. And so if they have like a specific issue that they really want to work on a clinic, we have some funding that they can apply for to, you know, implement a specific project. So for instance, right now we have some grants. We have a grant with a clinic up in Duluth to do some work around transition to adult health care. And then we also have a community of practice for people who provide care coordination to children. And so we have about 250 people actually who have joined our community of practice, and they, the different care coordinators, and that's who the community of practice is geared toward. And we provide them opportunities to network with each other, and then we also provide them a lot of trainings on how to provide care coordination, how to work with partners, you know, all of those kind of topics. So we also do a lot of work around advancing health equity for children and youth with special health needs populations. One thing we really do as a children and youth with special health needs program is to really promote the fact that we know that persons with disabilities or medical conditions, like the inherent fact of having that condition leads to disparities just as much as like race does in some situations. And so often a lot of our health equity work at the Department of Health is focused on like race or that kind of thing. And so a lot of what we've seen our role is also kind of promoting that like our families are really facing a lot of disparities because, you know, parents are having to cut back on their work or, you know, and so really promoting health equity from that perspective and not just, from like a purely racial standpoint. And then some of the ways that we're working to help, reduce disparities are around, like I said, promoting kind of that idea. We've also helping to increase access to parent support through like the grant that we have with Family Voices, and then also there's been some work around teleaudiology for families who live in rural areas. Basically, if you have a child identified with a hearing loss, like at newborn screening, they need to receive an evaluation. And we were finding a lot of families in rural areas weren't able to get those evaluations because there weren't audiologists near them. And so we've done a lot of work to try and improve access to the teleaudiology to help get children evaluated and hooked up to, like, linked with services more quickly. I mean, I would say it's not a but. That was, should not have had a but right there. I would say the bulk of the work that we really see ourselves doing in the Department of Health is around making connections. And so we know that families, that you guys all are having to interact with a whole lot of systems. And so we really see our role as being a convener and a bridge builder, along with, we also see our role as like, we know that some of the other systems don't do as good of a job engaging with families when they're making those decisions and doing those things. And so we see ourselves as like a convener that also kind of promotes the importance of connecting with families to help eliminate barriers between the systems. And so I mentioned briefly that, a lot of our funding is received by the Title V Maternal and Child Health Block Grant. And so I'm just going to cover a little bit of that because Tricia and Carolyn had asked me to. And so the Title V Maternal and Child Health Block Grant is really an example of a federal-state partnership. And so we receive funding from the federal government to help us in improving the health and well-being of our nation's mothers, children, including those with special health needs and families. And so that funding comes from the Federal Maternal and Child Health Bureau, which is located within, this is sort of like a chain. So the Maternal and Child Health Bureau is our direct partner in the federal government. They are located within the Health Services and Resources Administration, which is a part of the Federal Department of Health and Human Services. So at the federal level, they took their Department of Health, like Minnesota has a Department of Health that is separate from the Department of Human Services. At the federal level, they combined both of those agencies together and have one Department of Health and Human Services. And so our real purpose for Title V, like I said, is to improve the health and well-being of mothers, children, and their families. And so a little bit of history of our block grant. It started way back in as a part of the New Deal, if you remember from history class, Franklin Roosevelt's New Deal to help us get out of the Great Depression. And so it was Title V of the Social Security Act. Then during the Reagan administration, it was block granted, which just basically means they like Title V was kind of like a whole bunch of different varying services that they worked with. And so they block granted it to give sort of like like a specific amount to each state, and the state can choose to provide, as long as they're working toward improving systems for women and children and families, then, that kind of meets the requirements of the block grant. Although they found that there was still kind of a lot of confusion around that, and so they decided to add some additional accountability requirements to that in 1989, and of which they really kind of, the children and youth with special health needs were sort of lost a little bit when things were block granted, and so then in 1989 they really kind of beefed up, including children and youth with special health needs in the block grant again. And then just more recently, we have a new performance measure structure that they implemented as a part of the block grant, and they really see the purpose of the block grant from a bigger perspective now, I think, than they have, you know, in the, you know, past iterations. And so there are 6 population domains that the block grant focuses on. And so that includes women and maternal health, perinatal and infant health, child health, adolescent health, children with special health needs, and cross-cutting systems. And so as a state, we receive about $9 million from the federal government every year for our block grant. We are a part of that. By receiving that money, we are required to provide a match. And so we have to match 3 out of every $4 at the state level. And then there are also some requirements around those population domains, of how our money should be spent. And so, for instance, about 30% of our funding that we receive has to go toward services or support building systems for children with special health needs. I think I'm going to skip the performance measure structure because I don't know that it's that helpful. I'm going to have a cough up. A lot of talking. Our block grant runs on a 5-year cycle, and we just entered the last year of that 5-year cycle. And so we're doing some current needs assessment and strategic planning work that will inform our next cycle. And so the next cycle begins with the 2021 application and 2019 reports. And so Tricia is a part of a group that we have developed to do some strategic planning in our division that kind of is around our block grant. And so every 5 years as a part of the block grant, we have to do a comprehensive state needs assessment. The important thing to know about that needs assessment is that it is intended to be for all of maternal and child health, all of child and family health. And so children and youth with special health needs are a component of that, but they are not the only part of it. And so this slide has the 11 final priorities that we identified from our needs assessment. And we are now moving into a strategic planning process that we're working on. And we pulled together a steering committee for that strategic planning process back in January. And they really started meeting in June though. And our real goal in all of this work is to implement a community-focused process so that we can set strategies for a state plan that will guide work for the next 5 years. And so we, as a part of that, I see a chat. Oh, thanks, Jason. We have a strategic planning vision, and it's to improve outcomes and equity for Minnesota's children, women, families, and communities through authentic partnerships and shared decision making. We have, unfortunately, we've been using kind of the same process in our Title V work for the last probably 20 years. And it's been a very internal process, and we haven't been engaged much with our community and helping to set what our plan should be and what it is we should be doing. And so we really, with new leadership in our division, have decided to focus around really having authentic partnerships with our community partners, including families, and really having them as a part of our decision making. And so we are basically those 11 priorities that we have. There's been a strategy team that's compiled for each of them, and we are going to be moving forward, and each of those strategy teams are going to be challenged with coming up with 2 to 3 strategies for each of those priority needs that we had identified at the beginning. And so the one thing I really wanted to share with this is that, like I said before, in the past, you know, the little MDH like piece of the pie was like the whole pie before, and we have done so much work and have partnered with our community folks to really change kind of how it is that we're doing our work. And so only around like 17–18% of the people who are participating in our strategic plan are actually MDH employees, versus like 80–83% are actually like community folks, including a lot of like community members, folks from community parent organizations. And so I just wanted to share, as that is another kind of area where we as a division have really kind of worked to engage more with families.
Claire, if I could interject real quick. The big difference with the piece of pie, with the pie now versus the last time we did this and times in the past, the way this translates, just from my personal experience, has been, in this pie, this is families really purposefully being asked what's important to you, what needs our attention, versus someone asking my pediatrician what they think is important to me, or my county worker what they think is important to me, or public health in my county. What do you think is important to Tricia and families like hers? This is coming from the horse's mouth kind of stuff. And so it really is different and will inform kind of some of that trickle down work that we're going to feel the effects of going forward.
Mm-hmm. So I kind of compiled some thoughts on, you know, thinking from like your perspective as like a parent or you know, a caregiver, and knowing how intimidating it can be to work with state agencies, and state agency staff in particular can sometimes be difficult people. But I guess kind of the point I want to make in all of this is that like your voice is so critical in helping us really understand what families experience and need, and we can't do our work without having that voice. And so as like at MDH, we partner with families on very formal ways and in very informal ways. We also partner in very individual ways, and we partner also with like family organizations such as like our you know, Family Voices of Minnesota. And so I would say an example of a more formal way to partner with like us at the Department of Health or other state agencies is via some of our advisory groups that we have. And so a lot of the governor appointed advisory groups have announcements that are posted through the Secretary of State. And so when we hear really good opportunities for families to sit on advisory groups, we always reach out to our partners. We reach out to Family Voices or that kind of thing to really send out information to families. Otherwise, I guess I would say that like relationships, and in this work, like relationships are key. And so one thing that I've learned when partnering with families is the importance of like developing those relationships during like the good times, so that you've already got that connection with that state agency staff person before you need something, or so that like I've already got the connection with Trisha or Carolyn or whomever, you know, before I actually need to work with them. And so I guess I want to say, like, state agency staff, like, we're normal people who make mistakes and who have faults. And as a state agency, like, staff person, I will say, like, oftentimes it feels like I live and work in a fishbowl. Like, people are just waiting for us to, like, make a mistake. And so, and oftentimes, like, we are just as frustrated with the system as you guys are. And, like, all the red tape and stuff, like, we experience that as well. And it's just utterly frustrating. And so, I guess that's why, like, I come back to, like, the importance of having those, like, individual one-on-one relationships that you've already got built, because then you can really know people and you can understand, like, that, you know, we all have feelings and we're all trying our hardest. And, you know, it's a lot easier to be kind when you know someone and you know what motivates them and drives them and what their strengths are. And it's easier to work together to impact change when you have that connection already. And so that's just sort of my suggestion for you if you want to partner with other folks, or if you want to partner, you know, with us or that kind of thing. So that is it. That is all I have.
Well, Sarah, I can't thank you enough. I think that this has been really helpful, and I think that one thing that I want to point out is that this was a deep dive more so into MDH because this was the willing and eager connection we had with a state agency in Sarah Dunn to provide this information. We know that DHS and MDE intersect with our families quite often, and maybe even more so on a day-to-day basis that we can, you know, really see in our faces. That's really glaringly in our face. And I think that one of the challenges we have as family leaders is to take a look at some of the things that Sarah Dunn brought up today and think about ways that you can get involved and partnering with these state agencies. A little lesser known fact is that when you fill out those surveys that places like Family Voices send out, or when you have conversations with individuals here at Family Voices, when you make those connections with us, that information is tracked and passed along to the state agencies. It is not tied to you individually. Your personal information is not shared, but family needs are represented. So that's one way you can become involved and have a voice on the state level. I'm also going to include a link in the follow-up email to this that will have some vacancies for open committee assignments and positions throughout the state in these three areas. I'm going to include a link for that. Real quickly, is there anyone who has any questions for Sarah based on today's presentation? You can either speak up, take yourself off mute, or type something in the chat box and I'll read it for you.
It was a lot of information.
It was a lot of information, and I think that, you know, we're also going to make this recording available to you, not to be shared, please, but only to be reviewed by yourself if you want to kind of refresh your memory with the slides or the information. We will be sharing at least, I believe, the slides with you. Mm-hmm. And then we'll work on the recording. Give me a day to sort that out. I'm also going to send out an email to you as soon as we are off this call today. And it's going to have your session 2 assignment. It is due by 3 p.m. Next Friday, December 20th. The sooner you probably take a look at this, the easier it'll be to complete and get something out of. Although some of you like some processing time, and that's okay. Take a look at it so you know what to think about. It really is a brief survey format of an assignment, but we do appreciate you putting some thought into that. And also put some thought into the other two agencies that we didn't do a deep dive into. Think about ways that maybe we could partner as family leaders to represent those voices of many that we end up coming across every day.
Tricia?
Yeah.
Can I make a suggestion?
Please do.
I'm already serving on the Olmsted Community Engagement Work Group. And so maybe as people get connected with any of these boards or commissions or work groups that they are serving on, we can have updates to this group to maybe help move the mission or the conversation in bigger ways.
Absolutely. And I also wanted to make an announcement today. If there are many questions you come up with, send them my way via email or phone, and I will get in touch with Sarah to have those answered since we're running out of time today. A couple really important things. One, check that email that I'm going to be sending out. Number two, upon the suggestion of a wise and wonderful member of this cohort, we are going to have a monthly networking Zoom meeting that is going to, thank you, Don, that is going to allow you, if you're available and if you're interested, a time where we can just come together and we can share resources, we can talk about family leadership, engagement, partnership, and the different things that maybe are more specific to our own situation or our goals as a family leader. So I'll be sending out some dates and times where we're going to leave that an open possibility for you. It will start after the first of the year. And I will be in touch as soon as we hear back from our January presenter on a specific date and time. We're having trouble nailing them down, and so I apologize for the delay on that. But we are working to get all of those 2020 dates set so that it can be, so it can work with your schedule. Carolyn, was there anything you wanted to add today before we sign off 1 minute late?
No, thank you so much, Sarah.
Yep,
yes, Sarah, thank you so much for being a partner with families. We really appreciate it. We have talked about, too, also doing a Facebook group for Cohort 1 and Cohort 2 only. So we may be pulling that together and sending you a little invite for that. But I hope you all have a wonderful, happy holiday, healthy, safe, and holiday season. And know that we are here if you need to reach out, touch base with your mentors. They're valuable in this process. And we can't thank you enough for being a part of this family leadership journey with us. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thanks so much.
Thank you.
Thanks.